I'm Ross Camidge. I'm the Director of Thoracic Oncology at the University of Colorado Cancer Center. When you have ALK-positive lung cancer, you have this aberrant gene, ALK, which stands for anaplastic lymphoma kinase, which isn't normally active in most cells in an adult. It's been turned back on, and it starts issuing orders to tell your cells to behave like a cancer and grow and spread and divide and all those things. What targeted therapy does is it silences that signaling. So the gene is still there, but it's got a gag in its mouth. It can't issue those orders. And so like many kind of dictatorships, if you take away the orders being shouted from the top, the infrastructure falls apart. And so the cancer cells, deprived of that signaling, many of them will kind of shrivel up and die. And so you can get rapid and dramatic responses when you go on an ALK inhibitor, which is usually a pill. Now, it's not a cure, even if you have a dramatic response, because a tiny fraction of the cells will remain alive. And at some point, they will generate diversity. They'll still sort of be ticking over, and they will generate a variant of themselves, which is able to grow in the presence of these drugs. And that's when acquired resistance occurs, and something that's initially shrunk down will start to grow again. Now, you can rebiopsy, you can reanalyze, and we know some of the mechanisms by which acquired resistance can occur. Sometimes you can turn back on ALK signaling because the alteration stops the drug from binding, so that signaling reemerges. In that situation, sometimes a different ALK inhibitor is able to re-silence ALK and get the cancer back under control. However, in some situations, either the mutation occurs together with other mutations in ALK. That's called a compound mutation, and there are no currently available drugs that are licensed that work on those compound mutations. The other thing is sometimes you can still have suppressed ALK signaling, but you're essentially turning back on that messaging by having a completely separate pathway, a bypass track becoming active. And there, the best ALK inhibitor in the world isn't the answer on its own. You need that and another drug directed against whatever that other signaling pathway is. And the big challenge now is, can we figure out what those other signaling pathways are? Some of them we figured out: MET amplification, MET, MET mutation, HER2 amplification, have all been described in individual cases. And individual cases where somebody has added in a MET inhibitor or a HER2 inhibitor have been able to get some people's cancers back under control. That's going to be the next wave. The next wave is going to be about defining these second drivers. The future may even be about figuring out how you attack that little 1 in 10,000 cells that somehow survived the initial attack and were just lying dormant to generate these later mechanisms of resistance. But that's targeted therapy, both where it is and where the future's going.